3. Palliative medicine and symptom control. Introduction and general aspects. Palliative care is the active total care of patients who have advanced, progressive, life-shortening disease. It should be based on needs and not diagnosis, and is required in non-malignant diseases as well as in cancer. Box 3.1. Box 3.1. Key components of a modern palliative care service: management based on needs, not diagnosis. The symptom burden of non-malignant disease often equals that of cancer. Care that is independent of the patient's location and that helps patients to remain at home. If possible, avoiding unwanted admissions to hospital, rehabilitation for people with advanced disease, support for carers, bereavement care for people with pathological grief problems, telephone advice for other clinicians, dissemination of palliative care knowledge, teaching for clinicians, from undergraduate level to postgraduate lifelong learning. The goal of palliative care is to achieve the best possible quality of life for patients and their carers by managing physical, psychological, social and spiritual problems so as to provide excellent symptom control, enabling patients to be cared for and to die in the place of their choice, enabling the acceptance of death as a normal process when life-prolonging treatments no longer improve or maintain quality of life, providing the opportunity to say goodbye and bring closure. Who provides palliative care? A hallmark of palliative care is the multi-professional team, as single professionals cannot provide the breadth of necessary expertise. The emotional demands of working in this area require team support to enable balanced, compassionate and professional care. All healthcare providers should have basic palliative care skills and access to a specialist palliative care (SPC) team. They should be aware of the services that the local SPC teams can offer and recognize when referral is appropriate. A problem-based approach to disease management will ensure that patients and carers obtain access to appropriate support services, including SPC, and will avoid an either-or approach, either curative treatment or palliative care. Good communication between members of the healthcare team, and between patient and carer, underpins the successful management of advanced disease and end-of-life care. Effective liaison between the hospital, primary care and hospice is also essential. When should palliative care needs be assessed? Problems rather than prognosis. Early assessment of needs, with SPC referral if required, is crucial to achieving the best outcome for rehabilitation and for maintaining or improving quality of life for both patient and carer. Palliative care is most effective when it is included as part of routine care as soon as possible after diagnosis, alongside disease-specific therapy, such as radio, chemotherapy for cancer or cardiac medication for heart failure. Early referral links palliative care with quality of life improvements. Positive associations increase the likelihood that patients and families continue to use palliative care services when they need them over the course of the illness. In cancer, there is good evidence that integrating palliative care and anti-tumor treatment soon after diagnosis reduces long-term distress and increases survival in selected cases. If palliative care is seen only as relevant to the end-of-life phase, patients who have non-malignant disease are denied expert help for complex symptoms. Timely management of physical and psychosocial issues earlier in the course of disease prevents intractable problems later. Box 3.2. Box 3.2 Problems arising when specialist palliative care, SPC, is delayed until the end of life. There is insufficient time to achieve good symptom control by combining non-pharmacological and pharmacological components. SPC services are deemed less acceptable by patient and family, being associated with dying or giving up or giving in to illness. Psychological distress and physical symptoms become intractable and contribute to complex grief. It becomes too late to adopt a rehabilitative approach or use non-pharmacological interventions that need a degree of training and patient motivation, for example cognitive behavioral approaches, mindfulness meditation, attendance at day therapy. What are the patient's needs and what is the patient's understanding? The causes of a patient's symptoms are often multifactorial, and a holistic assessment is central for optimum management. Assessment of the patient's understanding of the disease, understanding their future wishes and acknowledging their concerns, will help the team plan and implement effective support. Patients will have differing needs for information, and will deal with bad news in different ways. A sensitive approach, respecting individual requirements, is crucial. How can patients use palliative care services? Changes in the provision of SPC services have been forced by the increase in the number of patients who survive malignant disease, as well as recognition of the needs of patients who have non-malignant disease. Many patients will use SPC services for a limited period, weeks to months, for complex problems to be addressed, and then are discharged. They have the opportunity for re-referral if help is required later. Symptom control. Good palliative care integrates the control of symptoms with appropriate non-pharmacological approaches, such as anxiety management and rehabilitation, CP. 36. Pain, see also pp. 818 to 820, is a feared symptom in cancer. At least 2/3 of people with cancer suffer significant pain. Pain has a number of causes, and not all pains respond equally well to opioid analgesics, figure 3.1. The pain is related to the tumor either directly, for example pressure on a nerve, or indirectly, for example due to weight loss or pressure ulcers. It may result from a comorbidity such as arthritis. Emotional and spiritual distress may be expressed as physical pain, termed opioid-irrelevant pain, or will exacerbate physical pain. Figure 3.1 Management of cancer pain. The term total pain encompasses a variety of influences that contribute to pain: biological, the cancer itself, cancer therapy, drugs, surgery, radiotherapy. Social, family distress, loss of independence, financial problems from job loss. Psychological, fear of dying, of pain, or of being in hospital, anger at dying or at the process of diagnosis and delays. Depression can stem from all of the above. Spiritual, fear of death, questions about life's meaning, guilt. A visual analog scale for pain can be used, figure 3.2. Figure 3.2 Visual analog scale for pain assessment. A verbal rating scale can also be used, none, mild, moderate, severe. The WHO analgesic ladder. Most cancer pain can be managed with oral or commonly used transdermal preparations. The World Health Organization, WHO, Cancer Pain Relief Ladder guides the choice of analgesic according to pain severity, figure 3.3, box 3.3. Figure 3.3 WHO analgesic ladder for cancer and other chronic pain. Step 2 can be omitted, going to morphine immediately. Adjuvant drugs are listed in box 3.3. Opioids include all drugs with an action similar to that of morphine, that is binding to endogenous opioid receptors. Continue non-steroidal anti-inflammatory drug, NSAIDs/paracetamol regularly when opioids started. Box 3.3 Commonly used adjuvant analgesics. Drugs indication non-steroidal anti-inflammatory drugs, NSAIDs, for example naproxen bone pain, inflammatory pain anticonvulsants, for example gabapentin, 600 to 2400 mg daily, or pregabalin, 150 mg at start, increasing up to 600 mg daily, neuropathic pain tricyclic antidepressants, for example amitriptyline, 10 to 75 mg daily, neuropathic pain bisphosphonates, for example disodium palmidronate, zoledronic acid metastatic bone disease dexamethasone neuropathic pain, inflammatory pain, for example liver capsule pain, headache from cerebral edema due to brain tumor. If regular use of optimum dosing, for example paracetamol 1 g times 4 daily for step 1, does not control the pain, then an analgesic from the next step of the ladder is prescribed. As pain has different physical etiologies, an adjuvant analgesic may be needed in addition, for example, the tricyclic antidepressant amitriptyline for neuropathic pain, see box 3.3. Strong opioid drugs dose titration and route morphine is the drug of choice and, in most circumstances, should be given regularly by mouth. The dose should be tailored to the individual's needs by allowing as required doses. Morphine does not have a ceiling effect. If a patient has needed further doses in addition to the regular daily dose, then the amount in the additional doses can be added to the following day's regular dose until the daily requirement becomes stable, a process called titration. When the stable daily dose requirement has been established, the morphine can be changed to a sustained release preparation. For example, 20 mg morphine elixir 4 hourly equals 120 mg morphine per day equals 60 mg twice daily of a 12-hour preparation or equals 120 mg daily of a 24-hour preparation. The starting dose of morphine is usually 5 to 10 mg every 4 hours, depending on patient size, renal function and whether a weak opioid is already being given. If there is significant renal dysfunction, morphine should be used in low doses and should not be given in continuous dose regimens, for example by subcutaneous infusions, because of the risk of metabolite accumulation. It is renally excreted. In renal impairment, an alternative opioid, for example fentanyl, can be given transdermally, for example 72-hour self-adhesive patches, or by subcutaneous infusion. Be a word of caution about opioid transdermal patches. Serum levels do not change quickly with transdermal patches, and they are also cumbersome to titrate in patients with escalating or unstable pain. They should be kept at a stable dose, and a more dose-responsive preparation used to gain pain control. If a patient is unable to take oral medication due to weakness, swallowing difficulties, or nausea and vomiting, the opioid should be given parenterally. For cancer patients who are likely to need continuous analgesia, continuous subcutaneous infusion is the preferred route. Both doctors and patients may have erroneous beliefs, such as the fear of addiction, which mean that adequate doses of opioids are not prescribed or taken. However, iatrogenic addiction is very rare, with the risk being less than 0.01%. The adverse effects and morbidity from uncontrolled pain are much higher. Side effects. The most common side effects are nausea and vomiting. These can usually be managed or prevented with antmetics, such as metoclopramide. Some antmetic solutions for injection can be combined with an opioid for continuous subcutaneous infusion, for example haloperidol or metoclopramide. Always check compatibility data. Constipation. This is common and should be anticipated with administration of a combination of stool softener, for example macrogols, and stimulants, either separately or in one preparation. Naltrexone is a peripherally acting opioid receptor antagonist that is used if response to other laxatives is poor. If side effects are intractable, a change of opioid is often helpful. Toxicity. Confusion, persistent and undue drowsiness, myoclonus, nightmares and hallucinations indicate opioid toxicity. This may follow rapid dose escalation and responds to dose reduction and slower retitration. It may indicate pain that is poorly responsive to opioids and the need for adjuvant analgesics. Antipsychotics such as haloperidol may help settle the patient's distress whilst waiting for resolution of toxicity. Some patients will tolerate an alternative opioid such as oxycodone better, or an alternative route such as subcutaneous injection. Adjuvant analgesics. The most commonly used adjuvant analgesics are described in box 3.3. Other treatments, such as radio, chemotherapy, anesthetic or neurosurgical interventions, acupuncture and transcutaneous electrical nerve stimulation, TENS, may be useful in selected patients. Gastrointestinal symptoms: anorexia, weight loss, malaise and weakness. These result from the cancer cachexia syndrome of advanced disease and carry a poor prognosis. Although attention to nutrition is necessary, the syndrome is mediated through chronic stimulation of the acute phase response, and tumor-secreted substances, for example lipid-mobilizing factor and proteolysis-inducing factor. Thus, calorie-protein support alone gives limited benefit. Parenteral feeding has been shown to make no difference to patient survival or quality of life. Management is supportive unless the patient is fit enough or in response to anti-tumor drugs. Specific therapies such as iosapentanoic acid, EPA, fish oil, cyclooxygenase, COX, inhibition with nonsteroidal anti-inflammatory drugs, NSAIDs, and antioxidant treatments are used. Advice from a dietitian is helpful. Some patients benefit from a trial of a food supplement that contains EPA and antioxidants. Megestrol may help appetite, but weight gain is usually caused by fluid or fat. The drug is also thrombogenic and is of little benefit and should therefore not be used. Corticosteroids were recommended as appetite stimulants and are still commonly used. However, the weight gained is usually caused by fluid, and muscle catabolism is accelerated, leading to a proximal myopathy. Any benefit in appetite stimulation tends to be short-lived. Thus, corticosteroids should be limited to short-term use only. Nausea and vomiting are common, and often due to use of opioids without antmetics such as haloperidol 1.5 mg times 1 to 2 daily or metoclopramide 10 to 20 mg times 3 daily. When nausea and vomiting are associated with chemotherapy, patients should have an antmetic, starting with metoclopramide or domperidone, but if the risk of nausea and vomiting is high, give a specific 5-hydroxytryptamine 3,5-HT3, antagonist, for example ondansetron 8 mg orally or by slow IV injection. Chemical causes, for example hypercalcemia. Haloperidol 1.5 to 3 mg daily is the first choice. Metoclopramide is also a prokinetic and therefore useful for emesis due to gastric stasis or constipation. Cyclizine 50 mg times 3 daily is also used. Any cause of vomiting. It may be necessary to start antmetic therapy parenterally by continuous subcutaneous infusion to gain control. If the patient has gastrointestinal obstruction, this route may need to be continued. Gastric distension due to pressure on the stomach by the tumor, squashed stomach syndrome, is treated with a prokinetic, for example, domperidone 10 mg times 3 daily. Bowel obstruction. Metoclopramide is helpful but to be avoided in complete bowel obstruction, where an antispasmodic such as high-osin-butyl bromide is preferred. A dose of 60 to 120 mg/24 hours SC is usually recommended, but much higher doses, 300 to 480 mg, may be needed as parenteral high-osin-butyl bromide can be rapidly inactivated in humans. Octreotide, a somatostatin analog, is commonly used in bowel obstruction to try to reduce gut secretions and the volume of vomitus, but a recent randomized controlled trial failed to show any benefit over placebo. Ranitidine may have a role in reducing gastric secretions. Physical measures, such as a defunctioning colostomy or a venting gastrostomy, may be helpful. Occasionally, a lower bowel obstruction is resolved with insertion of a stent, or transrectal resection of tumor in selected individuals. Steroids shorten the length of episodes of obstruction, if resolution is possible. In advanced disease, patients should be encouraged to drink and take small amounts of soft diet as they wish. With good mouth care, the sensation of thirst is often avoidable, thus sometimes preventing the need for parenteral fluids unless otherwise indicated. Further reading: Clark K., Lam L, Curro D. Reducing gastric secretions. A role for histamine 2 antagonists or proton pump inhibitors in malignant bowel obstruction. Support. Respiratory symptoms. Breathlessness remains one of the most distressing and common symptoms in palliative care, causing the patient serious discomfort. It is highly distressing for carers to witness. Full assessment and active treatment of all reversible conditions, such as drainage of pleural effusions, or optimization of treatment of heart failure or chronic pulmonary disease is mandatory. In advanced cancer, breathlessness is often multifactorial in origin and many of the contributory factors are irreversible, for example cachexia, so a complex intervention combining a number of different treatment strategies has the greatest impact. Aspects of breathlessness management are summarized in box 3.4. Intractable severe breathlessness in a patient who is dying may require sedation in order to provide comfort, but more invasive interventions are usually avoided. Non-invasive ventilation, NIF, has been shown to alleviate distressing dyspnea and is also associated with a reduced opioid requirement. This may be helpful in selected patients. Box 3.4 Key points for successful management of breathlessness. Start treatment early. Patients who are likely to develop breathlessness should learn non-pharmacological approaches early in the disease course, before breathlessness has become severe. Involve the carer in the treatment strategy. Watching breathlessness episodes and being unable to help is a terrifying experience, and promotes the panic-anxiety cycle. If patients and carers develop a joint ritual for crises, chronic anxiety can be reduced. Ensure management is rehabilitative, CP 36. This increases physical fitness, hope and self-efficacy, and may enable patient and carer to achieve goals.